You received a call from A&E about a patient who is a 30 years old female, right hand dominant, and had an episode of large piece of wood entering into the finger near the MCP joint. It stated that she was able to remove the wood piece. She has a punctured wound over the joint and is tender. There is increased pain with activity. It has been already 1 week. At physical examination, you review the patient in A&E. While at examination, there is edema and soft tissue swelling around the proximal interphalangeal joint of the index finger. Clearly, there is swelling. Active and passive range of motion is restricted and painful. There is no evidence of cellulitis. The aspiration was done and a turbid fluid was obtained. The differential here can be gout, psoriatic arthritis flare, or SLE. The diagnosis here can be septic pyogenic arthritis. For diagnostic studies, an aspiration should be always sent for 5 things, i.e. gram stain, culture, sensitivity, crystal analysis, and cytology. In septic arthritis, the joint fluid contains white blood cell count over 50,000 per millimeter cube. The polymorphonuclear count should be more than 75%, and the synovial fluid glucose is 40 milligram or lower. Radiographs are always taken out to rule out occult fractures, any foreign body, or signs of infection, i.e. osteomyelitis. Radiograph can be also used to determine the extent of articular cartilage destruction, bone loss. Here, the diagnosis of pyogenic septic arthritis of proximal interphalangeal joint has been made. The most common organism in septic arthritis of the joint is Staphylococcus aureus. This can happen because of heterogeneous or contagious spread, and can happen with postoperative infections with direct inoculation. A septic arthritis can cause articular cartilage destruction and osteomyelitis, and therefore aggressive surgical intervention is recommended. As per the guidelines, if the patient is not septic, antibiotics should be withheld until operative intervention is done. Anyhow, in this situation, the patient was febrile, therefore antibiotics were started. The antibiotics are empirical at the beginning, and later on, culture-specific antibiotics are started. Regarding the draining of proximal interphalangeal joint, there are 2 ways. Either you can give mid-axial incision on either side of the joint, or a direct dorsal incision. In the mid-axial incision, care should be taken to avoid neurovascular structures. An incision is made on the mid-axial plane on one side of the joint. In the finger section, the transverse retinacular ligament. The extensor lateral band is retracted dorsally, and the neurovascular bundle is retracted towards the palm. Once the collateral ligament is identified, a longitudinal incision made parallel and palmar to the ligament, separating the accessory ligament. A portion of collateral ligament is removed and the joint is drained. Specimen is sent for lab for aerobic and anaerobic cultures. The joint is copiously irrigated and the fibrinous and synovial debris is debrided. The wound can be packed for continuous bedside irrigation, or if the joint debridement is adequate, wound can be loosed closely. A bulky dressing is applied with a splint. If the joint is involved or the bone isn't destroyed, removal is necessary. Antibiotic impregnated spheres can be used, beads can be used in the reconstruction of the joint with arthrodesis or bone grafting once the infection has eliminated. Rarely, amputation is required. Postoperatively, the patient's hand is elevated for 24 hours after irrigation and allow the hand to rest and the soft tissue swelling to subside. The bandage must be changed and checked for drainage of the wound and ensure that there is no fluid in collection in the joint. Once the wound and the swelling calms down and dries up, the patient is allowed to have range of motion exercises. Wound is checked to continue and follow-up appointments in outpatient department is given.